Today, I would like to share with you the real-world evidence for biologics in chronic rhinosinusitis with nasal polyp in Taiwan. I work as Chief of the Rhinology Division in Department of Otolaryngology in National Taiwan University Hospital. I'm also right now the President of Taiwan Rhinology Society. We have the opportunity to use the biologics in the beginning when they enter Taiwan. So today I would like to share some of our experience with you. This is my disclaimer. First of all, I would like to introduce a little bit about chronic rhinosinusitis. From the chronological terminology, we can understand that for the understanding of chronic rhinosinusitis developed since 2000, we can see that the original term, we called it chronic peronasal sinusitis. And after that, we phenotype the chronic rhinosinusitis as with polyp or without polyp, because at that time we think that with polyp or without polyp is a very typical characteristics of this kind of sinusitis. Later on, because of the research, discovered that eosinophil became the very important infiltrating leukocyte in our sinus tissue. So eosinophilic chronic rhinosinusitis became a very important term in rhinology. But if you know that in EPOS 2020, we almost abandoned the phenotype with nasal polyp or without nasal polyp as the differentiation for the chronic rhinosinusitis. Instead, the type 2 information became most important characteristics to differentiate the chronic rhinosinusitis. You will know later on how type 2 information influence our treatment strategy in this era. For chronic rhinosinusitis, everybody knows that to start it with appropriate medical management is our first step. That includes some topical treatment and some systemic treatment. Topical treatment including topical antibiotics or topical steroid irrigation. But for systemic therapy, we can use oral steroid. And for sometimes we can use long-term low-dose macrolide to treat the chronic rhinosinusitis. But in the future, maybe the so-called biologics, the targeted biotherapeutic agent will become one of the important circle for the medical management. Of course, ENT doctor as a surgeon, we all know that the functional endoscopic sinus surgery is the mainstay to treat the chronic rhinosinusitis when the medical treatment failure. The main purpose of our surgical treatment, one is to correct the anatomical flaws, especially in osteomeatal complex and also some diseased sinuses. Another one is to decrease the inflammatory load, such as nasal polyp and polypoid mucosa, or thickened or irreversible change of the mucosa. We should remove it when surgical intervention. And with the open cavity, we can facilitate the healing process by giving all kinds of topical medication. So it's very clear that surgery follows the medical treatment to treat our chronic rhinosinusitis patient. EPOS 2020 started to classify our so-called chronic rhinosinusitis into type 2 and non-type 2 information. It's all because that most of the refractory sinusitis come from the so-called type 2 information. That will include such as localized chronic rhinosinusitis with allergic fungal rhinosinusitis, or chronic rhinosinusitis with nasal polyp, or eosinophilic chronic rhinosinusitis. And a new category was categorized, so-called central compartment atopic disease. These are all belong to the type 2 inflammation category. And it's all because that most of the type 2 inflammation will result in refractory sinusitis. That's why the EPOs especially classify the so-called type 2 inflammation recently. In recent article, we can see that the principle and the flowchart treat the chronic rhinosinusitis became is obvious in this flowchart. If the patient can be cured by previous strategy with appropriate medical treatment and enough endoscopic sinus surgery, then we have successful treatment for the patient. But the patient, if they have still persistent symptom or refractory symptom, what to do next? The next one is to go to another surgery, or we can do more with medical treatment. Now the biologics come into this treatment protocol. If we found that there is evidence for type 2 inflammation, then we might choose to use some biologics for these patients. So I think from the understanding of pathogenesis, the biologics became a good weapon for us to treat the refractory chronic rhinosinusitis. And for the moment, the available biologics in United States there are 4 types of biologics. The first one is the anti-IgE, and there are also anti-IL-5 and anti-IL-5 receptor, and anti-IL-4 and anti-IL-13. So how do we choose between these biologics? As I said that we target in the patient with refractory sinusitis. So in our country, we try to figure out what kind of patient is our target for using biologics. So we analyze from our insurance system to clarify who is the patient who need a revision surgery before. We know that revised surgery indicates a refractory chronic rhinosinusitis. In Canada, I think that maybe up to 20% of patients is refractory. In United States, the revised surgery average is 5 years. In the United Kingdom, almost 20% of patients need revised surgery in 5 years. And in Taiwan, we have very wide coverage of our insurance system. So we try to analyze from our data in the past 20 years to see the trend of these sinus surgery. From 2001 to 2018, we trace back all the patients who need endoscopic sinus surgery. In year 2000, we can see that almost in 1 year, we operate on 7,000 cases, but up to 2018, the number increased up to 12,000 cases. It means that we apply the surgery more and more in treating the chronic rhinosinusitis patients. And we analyze our revision cases. In these 10 years, we follow up patients after the first surgery. In 10 years, the revision rate is up to 14.5%. I think this is very similar with the Western country. It means that although receive the primary surgery, some patients are not satisfied with their result. So they will pursue another surgery in 10 years, and the number is 14.5%. This indicates the patient may need new surgery, new treatment, including revised surgery or new treatment strategy. And the time to revise surgery averagely is in 6 years. And what is the factor that will influence our risk, is the risk factor for revised surgery? You can see from the table that several factors are analyzed. And we use the Kaplan-Meier curve figure to analyze all these factors. But the conclusion is that the risk factor for revised surgery in Taiwan is younger age, the male gender, and the surgery which is performed in non-medical center, and the patient with pulmonary disease or nasal polyposis has higher risk of revised surgery. And when the first surgery takes longer times, it's also the risk factor for revised surgery. But in contrary, if you perform the concurrent septal surgery in the first operation, that would decrease the risk of the revision. I think this is a very good reference for the ENT doctor to understand what is the risk factor when you do the surgery for the patient. Actually, we 2 years ago, we have analyzed the risk factor for all the refractory sinusitis and published in Rhinology that we identified 2 factors that might be a risk factor for the refractory sinusitis. The first one is blood eosinophilia. I think it's very similar with Western country. That means that type 2 inflammation definitely is the risk factor for unsatisfied surgical intervention for chronic rhinosinusitis. The second factor is the sinus wall thickness, indicate that the long-term inflammation that will increase the neo-osteogenesis possibility. So the sinus wall thickness is also another risk factor for the refractory sinusitis. So from all the data, we can see that recalcitrant sinusitis is now a very important issue in our treatment of chronic rhinosinusitis. These include the symptom failure despite adequate surgery, and also all the adequate medical treatment for the patient. But what to do next for all these recalcitrant sinusitis? Actually, in Taiwan, we start to promote the so-called shared decision-making procedure for the patient. We want to share our medical knowledge to our patient. They then have a full understanding of our treatment strategy for the sinusitis. Then they may choose a second surgery, or they may choose more medical treatment or newer novel treatment strategy for their disease. So I think shared decision-making is a very important procedure when you want to advise the patient to take biologics as the treatment strategy. This is also appeared in 2016 by 2 renowned rhinologists in England and in Netherlands, the Professor Lund and Professor Folkens. They have made a flowchart to treat the chronic rhinosinusitis. They have identified that the patient with eosinophilia and the patient without eosinophilia is different group. But for the patient with eosinophilia, so-called type 2 inflammation, they suggest that biologics may be the choice to treat all these patients. So what is the evidence of the so-called type 2 inflammation in our patient group? Actually, the biologic developed for already more than 20 years. They started from the anti-IgE, and later on they are anti-IL-5 and anti-IL-4, etc. For these biologics, they have strong evidence from the research that these inflammation is a complicated network involved in so-called type 2 inflammation. And the major molecule involved in this type 2 inflammation, including interleukin 4, interleukin 5, interleukin 13, and Ig, etc. So that's why when they developed the so-called biologics, anti-IgE is the first one to be developed, and later on the anti-IL-4 also developed. For recent article, we can see that there is already meta-analysis to prove that the biologic treatment in selected patient, you can improve their subjective symptom by analyze with the SNOT-22. And they also can improve the objective nasal polyp score without any doubt. So this is good for the patient that if we use it properly, we can treat the patient with very good result. Of course, this is all because that we start to understand the pathogenesis of the chronic rhinosinusitis with so-called endotyping. Before, with nasal polyp or without nasal polyp, is a so-called phenotyping. But with endotyping, we start to understand the pathogenesis more. This kind of endotyping started from 2016 by Professor Bucket. He published a paper mentioned about how to categorize or subgroup using so-called tissue molecular to differentiate 10 clusters of the so-called chronic rhinosinusitis. As you can see from this figure, they try to cluster the rhinosinusitis by using interleukin-5 amount, IgE amount, ECP, and neutrophilic inflammatory marker, etc. And you can see for the type 2 inflammation, it's very clearly that the interleukin-5 is increased, IgE is increased, and eosinophilic canine protein also increased in this kind of tissue. And these patients has more probability with comorbidity, with asthma, etc. So started from that point, many subclassification and endotyping started all over the world. But from the data now, we can see that although type 2 inflammation is very important in Western country, but actually in Asian countries, especially in China, we can see that less number of the type 2 inflammation in our group compared to in Western country. In Western country, they say that more than 80 to 90% of the chronic rhinosinusitis patient with polyp belong to the type 2 inflammation. But actually from data in mainland China and in Taiwan, we think that the percentage of type 2 inflammation may be only 40 to 60%. So from our hospital, we try to also find out what kind of patient is the main target of the biologic treatment. We use the clinical analysis, and also we try to find out from our tissue to see what's the main characteristic of our patient in so-called type 2 inflammation. As you can see from this figure, that if we divided so-called eosinophilia or non-eosinophilia patient, for the eosinophilic chronic rhinosinusitis, the patient tissue has a higher amount of IgE and IL-5 and IL-13, but not IL-4. But instead, with the patient with comorbid asthma, they will express more IgE in the tissue and IL-5 in the tissue. And the patient with allergy has higher IgE expression. Another group is the so-called central compartment atopic disease, CCAD patients. In the tissue, we can find more interleukin-13 in our patient. And this is the table that would demonstrate that the relationship of type 2 inflammation factor with the phenotype. We can see that the patient with asthma comorbidity has more eosinophilic inflammation. And the patient with smell problem, and in the tissue, we can see more eosinophil count and basophil count. And also indicates that the ethmoid maxillary ratio is also related to so-called eosinophilic chronic rhinosinusitis. And CCAD is especially related to eosinophilic chronic rhinosinusitis. And in this figure, the eosinophil count is higher in this group. And so, in summary, we can see that actually if we find from the tissue for the eosinophilic chronic rhinosinusitis, we can see that the marker of interleukin-5, IgE is increased, but not IL-4. But IL-13 is increased in central compartment type. So what happened to interleukin-4? You can see that in Professor Bucket's analysis, he didn't mention the IL-4, the role in type 2 inflammation, but actually from the Nature article in 2018, it demonstrated clearly that actually interleukin-4 is more upstream than the interleukin-5 in IgE expressed in so-called nasal epithelial cell. You can see if you obtain the epithelial cell from the nasal polyp, there are more basal cell proliferation. And in these basal cell, the basal cell becomes stuck in the interleukin-4 and interleukin-13 signature. Means that downstream to the interleukin-4, there are so many molecules will upregulate in nasal polyp tissue. If you treat these nasal polyp epithelial cell with anti-interleukin-4, you can reverse this kind of inflammation by using interleukin-4 blockade. So I think interleukin-4 may be more upstream than so-called interleukin-5 and IgE. So in summary, for our treatment strategies right now, although we treat even type 2 inflammation and not non-type 2 inflammation with surgery as the first step of the treatment, but biologics now come into our treatment protocol. If we fail to treat the patient type 2 inflammation with surgery, I think biologics will definitely play some role in the treatment protocol. In Taiwan, we start to use the biologics since last year. I think the most important point is that who and when and what and how can be used these biologics. We can reference from many articles from Western country. For example, the EPOS 2020 has mentioned that we need a 3 criteria fit in these 5 criteria to select the patient optimal for the treatment of using biologics. There are so many different countries has already defined the consensus for the biological use. We, Taiwan Rhinology Society, has also recently made the consensus on the practical use of biologics for the patient. Of course, they include 3 steps. The first step is that we have to have the baseline requirement. These patients are definite with the chronic rhinosinusitis with nasal polyp and has enough disease burden. And also the step 2 is to have 3 criteria fit in 5 different criteria to fit the so-called type 2 inflammation evidence. The step 3 is to have the outcome evaluation to prove that these patients are suitable for a biologic treatment. We have our own Chinese version of our Taiwan Rhinology Society indicate consensus to suggest our members to use the biologics. The detail I will not be mentioned in this talk. The current available biologics in Taiwan, actually, there are 3 types. The first one is anti-IgE, and the second is the anti-IL-4, the Dupixent, and the third is anti-IL-5. Actually, all these biologics are not covered by our insurance system yet. So you can imagine that it's very expensive medication for the patient. So it's very difficult to promote the biologic for the patient. So we have to be cautious when you suggest the biologics for the patient. For now, the indication are all fit for these 3, but only reimbursed for the allergic asthma for Xolair. The Dupixent has the indication for the chronic rhinosinusitis with nasal polyp, but still is only reimbursed from the insurance for the atopic dermatitis. And for the Nucala anti-IL-5, they have indication for the nasal polyp, but it's only reimbursed for the asthma. For now, we have used biologics in our patient group. We summarize our data that we have used in 57 patients using Dupixent. In 6 patients, we use Xolair. Actually, we don't really use the patient only in very severe one. Of course, from the reference, we know that you need a certain nasal polyp burden that is suitable for the patient selection. But we try to use our patient also in the so-called adjuvant therapy. Means that the patient received the first surgery, but we can use it immediately after operation. Sometimes we can get a very good result. This is the summary that we have our biologic use in our patient. This is the detailed information of our patient. I would mention a few cases for you. This is a very severe patient that's a 59 years old male patient. He has been operated for 3 times. And the last operation resulted in a very severe status asthmaticus. So he has to receive the tracheostomy and then admitted to ICU for several days. This patient has obvious AERD, and his blood eosinophil count is very high, IgE very high. So we have no choice. We don't do another surgery for him. We have to give him the biologics. So when he before he received the biologics, you can see that it's filled with all the nasal polyp, and the tissue shows very marked eosinophil infiltration. With 2 doses of Dupixent, you can see that the nasal polyp regressed dramatically, and the patient feels subjectively very well. And for 10 years, he cannot smell anything, but he started to smell something after 2 doses of Dupixent. Of course, unfortunately, after 2 doses of Dupixent, because of financial problem, he cannot receive continuous treatment. After 3 months, the polyps start to regrow a little bit. But I think this is the evidence that I think in selected patients, the so-called biologics is really effective for these suffer patients. The case 2 is also a patient that received 4 times operation before. He continued to follow up in my OPD for 5 years. Recently, I suggest him to use the biologics. And of course, the pathology show also eosinophil infiltration in his tissue. But after 2nd dose of Dupixent, the polyp regressed dramatically. After 5th dose, all the polyp disappeared, and the patient also regained his smell without any problem. The 3rd case is the adjuvant use of the biologics. This patient is a characteristic allergic fungal disease patient. We first do the surgery to remove the allergic mucin from his sphenoid sinus. But immediately after surgery, during 1 month of the follow-up period, a lot of allergic mucin retained again in his sphenoid sinus. And I think maybe biologic is good for him. So we give him 2 doses of the Dupixent, and the follow-up became fantastic. And he never developed another allergic mucin after 3 months follow-up. The 4th case is also a typical type 2 inflammation patient with anosmia. This is a fresh case, so we try to use the adjuvant treatment. He has evidence of the type 2 inflammation, including the allergic characteristic and IgE increased. And before surgery, you can see that the diffuse nasal polyp was found in CT scan. And from endoscope, you can see that nasal polyp is obvious. During surgery, it's very sophisticated. We try to remove all the nasal polyp. And I didn't obtain a postoperative figure yet, but the result is excellent because a patient replied that he regained his smell from anosmia to 100% of smell after postoperative 10 days. So in summary, I think there are some excellent response to biologic in selected chronic rhinosinusitis patient with nasal polyp in Taiwan. Maybe additional benefit for postoperative mucosa healing was good for these adjuvant use of the cases. The most novel article I found in Rhinology in this month is that the German group published their real-world effectiveness for biologic treatment for the chronic rhinosinusitis with nasal polyp patient. They say that almost 90% of the patient show a moderate to excellent response to therapy. I think we have the same result that if you carefully select your patient, I think biologics is really effective for a certain group of patients. And thank you for your attention. This is my sharing with you, my experience with the biologic use in Taiwan. Thank you.